All right, Dr. Kerr, thanks for giving me a heads up. Are you able to see the main screen?
Yes.
Okay, terrific. So addressing suicide in pediatric primary care, legal and ethical implications. We're going to go ahead and get started with some introductions of our attendees. Of our panel, and then we'll go ahead and get started with sharing some information here. So let me first introduce our goals and objectives. So today we will be discussing the role of PCPs in the treatment of suicidal ideation, identifying those practical implications of completed suicide in the clinical setting, and then as well as articulating the risks that PCPs face in identification and treatment of suicidality. Let me introduce you first to our first panelist, Dr. Baranowski. Dr. Baranowski is the Vice President and Chief Legal Officer at the University of Texas at Tyler, UTT. Dr. Baranowski leads legal aspects of the institution, its strategical and tactical initiatives. He advises senior leadership and manages the legal function and oversees the entire work of outside counsel. Before he joined University of Texas at Tyler, he served 10 years as counsel to a $3 billion multi-state hospital system. So to tell you that Dr. Baranowski knows what he's doing is an understatement. So let me share with you our next panelist, Dr. Catherine Kerr. Dr. Kerr is a child and adolescent psychiatrist with CPAN, with our CPAN team here at UT Health Science Center in Tyler, and is also a board certified pediatrician. Dr. Kerr is a fellow in the American Academy of Pediatrics, having completed her medical training at UTMB in Galveston and her residency in pediatrics, general psych, and child psych at the University of Kentucky. Dr. Kerr is one of our 3 CPAN child and adolescent psychiatrists who's here to provide services for those of you who are registered with CPAN. She enjoys educating those providers so that her education is her passion, and likes to share information and education on medications used to treat mental health conditions in children, as well as the interplay between the physical and the mental health. Her areas of specialty include treatment of attention deficit hyperactivity disorder, early childhood mental health in primary care, and college mental health. Our next panelist today is Dr. Marinel Munda. Dr. Munda is a board certified pediatrician and is working here with UT Health East Texas Physicians in Tyler. And Dr. Munda is also a fellow with the American Academy of Pediatrics, having completed her medical training in the Philippines and her pediatric residency in New York. Dr. Munda believes that children are an integral part of our community and should be given every opportunity to reach their potential. Through her ability to partner with parents, she feels that she has a unique and vital role, as I suspect that many of you do, in guiding, inspiring, and reaching out to children, not only to assist them in maintaining good health, but to also grow into the mature, productive members of society. Our final panelist today is Wiley Barton. Wiley is also on our CPAN team as an licensed professional counselor supervisor with more than 20 years of experience in the mental health field. Wiley is one of the 2 therapists who will answer the phones when you call into our team. So if you've been utilizing our services, our free certified services so far, you may have already spoken with him. Wiley has a wide range of experiences, including Director of Crisis Services at a local LMHA, counseling at a women's shelter, as well as counseling young girls in treatment, residential treatment. He's also had some time working in private practice. His specialty areas include working with children, couples, and families. While his specialized training includes trauma-focused CBT and CPT, he has completed independent competency ratings with the American Academy of Cognitive Behavioral Therapy. He continues to build his skill set, recently completing more than 5 years of training in biblical counseling. Please welcome today's panelists.
Is that Dr. Matthews?
All righty. So we have today our panelists. You'll see Are you all able to see our four panelists? I just want to make sure. Okay.
Yes, we can see everyone.
Excellent, excellent. So we have at the top Dr. Munda, at your top right, Dr. Baranowski, bottom right, Dr. Kerr, and Wiley Martin on your bottom left. At least that's how it shows on my screen. So I'm going to go ahead and turn this over to Mr. Baranowski. Will you go ahead and get started, please, today?
Sure, I'd be happy to. Appreciate the opportunity to be on the panel today. Speaking of primary care physicians and child suicide, primary care physicians are an important part of suicide prevention. Patients dying by suicide visit primary care physicians more than twice as often as mental health clinicians. 45% of those dying by suicide saw their primary care physician in the month before their death, while only 20% saw a mental health professional. And generalists, internists, pediatricians, family physicians write about 62% of the antidepressant prescriptions in the US. So that's important gatekeepers, at least, is part of the role of a PCP. And while suicide risk is not specifically mentioned in the Texas Family Code, here's another obligation on the part of PCPs. Reportable abuse, which must be reported under the Family Code, at least according to a guide that is provided by the Texas Department of Family and Protective Services, specifically includes reporting a suicidal child. So while the law applies to all citizens, healthcare professionals, which include a PCP, must report abuse within 48 hours of obtaining knowledge of the abuse, of obtaining knowledge of a suicidal child. Needless to say, there's a lot of gray area in this. There's a lot of room for judgment, and as a result, there's some room for potential liability. Professionals must also report when an adult was a victim of abuse or neglect as a child, and that reporting is necessary to protect another child, an elderly person, or a disabled person. So it's not just reporting a child that's suicidal, but an adult that may have experienced abuse, that and a result of the reporting may be useful in preventing abuse of another child or an elderly person or a disabled person. Failure to report can be a misdemeanor, or in more culpable failures, a felony. And it can also be a factor in obtaining or retaining licensure to practice. Now, PCPs may feel insufficiently qualified to recognize and treat patients for serious suicidal ideation. Malpractice suits can happen and usually involve Monday quarterbacking, which is always a Pro Bowl quality, of course. And it's a relatively imprecise means for identifying the vulnerable. I mean, it's not like, as opposed to COVID, where you can just stick the giant Q-tip into somebody and determine whether they have COVID. Determining whether someone is suicidal is difficult. People with suicidal thoughts very seldom actually commit suicide. It's a very small percentage. How do you know? How do you know what's going to continue from ideation to suicide? It's just a difficult situation to be in, but a necessary one for PCP. Now let's talk about malpractice now, in terms of a lot of the concern with the PCP is, I don't feel qualified, and do I refer, do I treat, what's my role, and what are the risks? Most of the risks that I'm involved in would relate to potential malpractice. And about half of primary care physicians report being sued for malpractice at some point in their career. It's 52% according to the last statistic that I saw. But that's compared to 62% of specialists. Now, if PCPs and psychiatrists were, if you include them as specialties, each one as a practice niche, PCPs would not make the top 10 of most frequently sued. Most likely the bottom 10. So the overall risk is relatively low. I mean, it can happen, and if it happens to you, then it's of concern, of course. But general surgery actually ranks first, with about 85% of general surgeons reporting that they've been sued for malpractice in their career. Also, Texas, probably thanks to tort reform that occurred some decades ago, and has been continued, Texas doesn't make the top 10 in the states anymore in percentage of physicians who've been sued. Kentucky claims that title with 75%. Texas is probably less than 50%. So the best way, and also if you're want to gauge relative malpractice risk, one of the best ways to do that is to compare your malpractice premiums with somebody in another practice, with a general surgeon. The same is true in law. If you're a securities lawyer, your malpractice insurance is going to be about 3 times what it would be if you were in another field, like working for the state. That's another way to gauge malpractice risk. So the risk is low, but nevertheless, it is real. And so what is malpractice? There's several elements that make up malpractice. And you have to have a doctor-patient relationship. As an example, a relationship is not established when a minor patient is referred to a psychiatrist. The psychiatrist knows of the referral, but the parents do not make an appointment. That's the parent's responsibility. That does not establish a relationship between the doctor and the patient. Now, a doctor-patient relationship can be established when a person presents at an emergency room and the psychiatrist has agreed to be on call in the emergency room. So there has to be negligence. In other words, doing something that a reasonably prudent person would not do, or not doing something that a reasonably prudent provider in that situation would have done. And there must be a bad outcome resulting from the negligence, and the causality can be clouded by different factors. Someone has suicidal ideation, they go home, they're not hospitalized as an immediate threat, they overdose on a medication in the home and die. Suicide. So there are several intervening factors. Who prescribed it? Was it there? Was another provider prescribing the medication for another condition? Were there guns or other means of committing suicide in the home that could have also resulted in that? So that goes into allocation of damages and causality. If there's not causality, there's not a malpractice suit. And there must be damages resulting from the suicide. Of course, there's the decedent, the person that died, but that person can no longer claim those around that person. There's medical expenses, funeral expenses, lost earnings, mental anguish of those that are left behind. And all those, there's clouding factors that I won't get into, but happy to answer questions. And lastly, and one of the more difficult ones in Texas, is you have to have standing. It takes a particular relationship with the decedent to be able to sue for malpractice. Texas law prohibits anyone who is not a spouse, parent, or child of the deceased from filing a wrongful death action. And this includes many people who could be devastated, like siblings or grandparents. They don't have standing. A spouse is also a legally married partner. Significant others do not have standing. So there are also some aspects into malpractice and managed care, but they don't really relate to the conclusion here. So if people have questions, I can get into them. But the conclusion that I have reached from the research and the cases that I have dealt with, it's reasonable for a PCP to refer possibly suicidal patients to a specialist. That is the standard of care, and the standard of care is evolving. And as practice gets more sophisticated, that standard of care is pushing medicine more toward specialties. Yet, given the PCP's de facto role as a gatekeeper and applicable provisions of the Texas Family Code, the standard of care for a PCP requires the ability to recognize depression, to question for suicidal ideation, and to consequently report, and then also to treat or refer to a specialist. So there is a duty, there is a risk. That's it for me, for now.
Thank you, Carl. We appreciate your time very much. And For those who are attending, I did put a little note in the chat. If you have questions for our panelists, please pop those in the chat and we will get to those at the end. Thank you. Dr. Kerr, I'm going to hand it over to you.
Yeah, I just wanted to welcome everyone and thank you for joining us. Because September is National Suicide Prevention Awareness Month, that's why we specifically chose to talk about kind of the role of pediatric primary care providers in suicide prevention, how you all as primary care providers can help. And so Carl gave us some, help information about your kind of legal role, but I want to talk a little bit about just some other concerns that may come up and kind of help you to feel more comfortable and empowered in your role in preventing suicide. So some of these statistics that I'm going to share may be familiar to you. Some of them Carl actually shared as well. And my colleagues and I actually gave a presentation on suicide screening in primary care in May that should be on the YouTube channel if you want to go back and reference it. So some of these may be familiar if you joined us for that. But we know that suicide is the second leading cause of death in ages 10 to 24. The first leading cause of death is accidents, and some of those are preventable. And as pediatricians, we're trained to work on some accident prevention. Some accidents are not preventable, but I would argue that suicide in a lot of cases is preventable. And so we can do our part in decreasing this second leading cause of death by working on prevention. And I know in my pediatric training, we did a lot of focus on anticipatory guidance and how to, prevention of illnesses with kids. And I would encourage you all to think of prevention of suicide as just another preventive measure that you are talking about with your families. So you might wonder, how can I even help prevent suicide? What can I do as a primary care provider? We know there are certain risk factors for suicide attempts. One of the strongest risk factors is actually a previous suicide attempt. So someone who has attempted previously is at a higher risk of attempting again. But other known risk factors are, having symptoms of depression, anxiety, impulsivity, history of physical or sexual abuse. The LGBTQ population has an elevated risk, even having a chronic medical illness. And these are all those things that I listed are all things that we typically do ask our patients about in the primary care setting. We ask about, we're screening for mental health illness, and we obviously know if our patients have chronic medical illness. And we typically know kind of how to handle those things. But another risk factor for suicide attempts is suicidal ideation. And as Carl said, not everyone who has suicidal ideation will go on to attempt, but we do know that it is a risk factor that we see at a higher rate in people who do attempt. And I know many providers are hesitant to ask about suicidal thoughts for various different reasons. And it's not, it's definitely a challenging topic, something that even I, as a child psychiatrist with extra training, still don't feel, when a kid answers yes to the question, I still have, kind of anxiety about, okay, what do I have to do next? And I think that it'll never be easy to handle this topic, but more experience and education on it can definitely help with comfort level. And so between today's panel, and then we also have a second panel in 2 weeks on the 15th, where we're going to talk a little bit more about safety planning and other strategies. I hope that between these two panels, we can address some of your concerns and also illustrate your important role as primary care providers in prevention and suicide prevention. Some other things we know about suicidal ideation in adolescents, based on a 2019 survey of high school teachers, 8.9%, high school students, 8.9% of high school students had attempted suicide within the past year, and 18.8% had reported seriously considering a suicide in the past year. And the data isn't, this survey is done every couple of years, and this data, 2019 is the most recent data that we have, but I imagine with COVID and all the things that our teenage patients have been dealing with for the past 18 months, that we will probably see increases in those numbers. We also know, as Carl shared, 80% of adolescents who die by suicide will have visited a healthcare provider within the first year, and 38% of adolescent patients who died by suicide will actually have seen a provider within the previous month. And 70% of adolescent patients in general, regardless of diagnosis or mental health conditions, will see their pediatrician or primary care doctor at least once a year for well checks or whatnot. So it does make primary care providers and the primary care clinic visit kind of an obvious intervention point because it is reaching such a large part of the adolescent population. But we know that primary care providers are already dealing with a lot with limited resources. And some of the barriers that PCPs identify in asking about suicidality include, limited time and resources, difficulty in interpreting suicidal ideation or behavior. So is saying that I want to die in the middle of kind of a meltdown after not getting what you wanted the same as, a teenage girl that's cutting her wrists? Stigma is another kind of barrier, and kind of lack of training or comfort with how to ask these questions and how to ask them effectively. And then just personal provider discomfort, just it's a hard topic to ask about. And so, like I said, we're not going to talk a ton today about kind of the specifics of how to ask, how to suicide screen in your clinics. We have that presentation available for you if you'd like to review it. But today I just wanted to focus more on kind of the importance of talking with adolescents about suicide and to address some of your concerns. And so a big concern that I wanted to address is that asking about suicidal thoughts will plant the idea in a child's head, even if they've never had it before. That if I ask, a patient, have you had thoughts about wanting to kill yourself, that they will then have thoughts that they weren't having before. And this has actually been studied, and there's no increased risk of suicidal thoughts after being asked about suicide. So there's no concern that just by asking about it that you're going to increase the risk. And in fact, some patients feel kind of comforted by their providers, especially their primary care providers, who they often have an established relationship with, asking about it, and it makes kind of like that they feel cared about and valued. And also, other patients may be hesitant to kind of spontaneously report these thoughts. We know that a lot of patients will not kind of spontaneously share that they are having suicidal thoughts with a provider. They may make an appointment for stomach aches or other things, but unless you ask them directly, they may not tell you. And so if we never ask patients directly about suicidal thoughts, we may never know that they really are struggling, and we're going to miss the opportunity to intervene. So in the same way that if we don't check a blood pressure on our patients, we may never know that they have hypertension. If we don't ask about suicidal thoughts, we may never know that they're experiencing suicidality until it is too late. So I think it's really important to ask. And as a child psychiatrist who is mainly doing child psychiatry now, I know I could sit here and tell you about how important it is to ask, and how we have these screening tools to help you. But I know that a lot of times it's better to hear about this from someone who's actually in the trenches, someone who's in an office like your own. And so now I want to shift gears and introduce you to Dr. Marinel Munda, who's a pediatrician with UT Health East Texas Physicians, and she's been a really great partner with us on the CPAN team. And I'm going to ask her a couple questions to get her opinion as a pediatrician who's kind of in the trenches on the front lines. So Dr. Munda, thank you for joining us today. We really appreciate you taking your time. And first, I was wondering if you could just tell us a little bit about yourself. How long have you been in practice, and maybe what made you choose pediatrics as a specialty? Dr. Munda, you're muted.
I graduated pediatric residency in 1995, so about 26 years. So when I was in high school, I taught catechism, and it came natural for me to teach with little kids. And so I knew I'm going to do something with children. Then when I did my clerkship, I rotated with NICU and nursery, and just holding baby gives me a calming effect. So I definitely at that time knew I'm going to do pediatrics.
Yeah, and so funny that you mentioned about the holding babies and really enjoying like young children. I know that a lot of my friends in residency that became general pediatricians, that's some of their favorite parts is the well child visits. And so I'm curious, coming out of residency, how comfortable did you feel with treating mental health in your clinic and treating adolescent patients who maybe aren't as cute as our little babies?
So I did not have much training in mental health, treating mental health. So I felt very uneasy. So I usually steer away from that. And the only probably mental issues that I have dealt with is ADHD, and I've treated fair amount of that throughout the years. But I really have not had much treatment, much experience about it. So until probably recently. And what happened is, like, I've been seeing a lot of kids very anxious, depressed, and I really don't know how to approach it. How to begin. I read so much about it, but still, that I don't have any experience. Okay, and it's very heartbreaking for me to see patients telling you that, and you're like helpless. The first instinct I would do is like refer to psychiatry, but there's not enough. Sometimes it takes 6 months to a year to be seen. And for the meantime, you feel like, you're not doing anything. And that's what our role in their lives is, like, to make them feel better right away. Your infection in like 1 week, they're better, but this is not something you can just treat and, get better within like a week. So, so my first instinct is to refer and then send them to a psychologist. But for the meantime, there's not much I can do for them. Until, I've heard about CPAN and again, read about more about anxiety and depression. And for the meantime, they are in between being referred and being seen by the psychologist, and that I partner with them. I felt like I have a role to not just listen to them, to treat them. And, it depends on the severity of their anxiety and depression. I may or may not give medication. And you guys, you three of you, I've been calling you and helping me with how to adjust medication and treat them. Another thing that, what has helped is, when CPAN opened, they gave me some toolkits to give my patients to start, answering questions. And that gives me a more gauge of how the patient is doing, like the PHQ-9, the GAT and the scared. And including in that is the ASQ if they have any suicidal thoughts.
Great. And what do you think is the hardest part? I think you elaborate on some of this, but the hardest part of treating patients with mental health conditions, or of you personally taking on some of that treatment?
Right. So first of all, we are so busy, especially now. We're seeing 30 patients a day together with RSV and COVID. So the hardest part for us, I feel like, is lack of time. And you mentioned that earlier, is the barrier to treat kids with mental health is, we don't have enough time to see them. Second is, of course, the experience in treating mental health. We're not equipped. We were not trained for it. So those are the two that I feel like is the hardest part in treating mental health, coming from a primary care physician.
Yeah, absolutely. And those are both, I think, very valid things. What do you think is the most rewarding part when you work with kids with mental health?
Well, just like the rewarding part is, how they improve through time. And you probably see this every day in your practice, seeing an anxious, depressed child to, after like 1 to 2 months with the help of like cognitive behavior therapy and medication, they you see their smile when they come back, and definitely the decrease of suicidal ideation. It's almost like you're empowered to do something rather than wait for the patient to be seen.
Absolutely. And that's, I think, a big goal of us at CPAN is we want to empower you as the primary care physicians to not feel so helpless in this. Mm-hmm. We all know that lack of resources is such a huge problem right now. And it's hard as the primary care provider, who is kind of the central part of the patient's care, to feel so helpless and, how can I help this family? So we definitely want
to just help. Like what Mr. Carl was saying, we're the gatekeepers.
Absolutely. Do you feel comfortable asking your patients about suicidal thoughts?
Initially, no. It's still hard for me to even ask that. Um, uh, uh, but when you did the lectures on suicidal, thought ideation in your past lecture, you gave us the ASQ, a screening tool. It's almost like part of our questionnaire now is to ask for that. So, sometimes my nurse would even ask that, and we'll have the parents come out, and um, if we feel like there is a possibility that the patient does not want the parents to be there. So that's what we do here. Sometimes it will come out, especially if they have like a chronic illnesses and or have come to me with several different symptoms, and I cannot pinpoint on any one of, like, I can't give a diagnosis. Sometimes it's almost like they're crying out for help. Then we can, we sit down and ask if there's, if he or she has any thoughts of hurting herself.
And have you had patients answer yes? And if so, how have you handled that in your practice?
So when somebody told me yes, of course I get nervous and like, oh my gosh, do I have to call, initially before you guys came is my first instinct is to send to the ER, or I don't want to be liable for if the child's committed suicide. Then I categorize them in like, do you have any thoughts right now? Do you have any plans? Have you attempted in the past? So almost like screening them, whether it is low risk, medium risk, or imminent risk. So that from that, I made a decision what to do with the patient, and I have to say, for the last year that I've been starting to do this, there's probably only one that I have to send to the ER that you can definitely see that there is an imminent danger to the patient. Most of them are low risk, and talking to them, giving them some safety plans, is very helpful, and constant communication with the parent, and usually the parent's on board.
Yeah, I think that's so important, just communicating with the family and coming up with a good plan.
Yes.
What advice would you have for a provider who is hesitant to screen patients for suicidal thoughts, or hesitant to ask that question?
Man, I get it. I was definitely afraid to ask them, thinking it may put it in their mind, and you even said earlier, studies have refuted that, that we're not suggesting they have to think about it, but most kids would want to disclose it to someone. And being, us seeing them from birth to adolescence and being part of their whole life, we are in a very unique place in their life to relate to them, and then they trust us. So I think we have a very vital role in helping these kids.
Yeah, and that was actually going to be kind of my last question, is kind of a softball, I guess. Do you think that pediatricians and family care providers play an important role in suicide prevention in adolescents?
I think we definitely have a big role in prevention, because we see them more often. And, the statistics have shown that, we see them within that year, and well checks, it could be a part of that. And it takes us like few seconds to even ask. And, it's almost like triaging. And again, not a lot of these kids needed to go to the ER, or, most of them are really low risk, they, again, sometimes come back with so many vague symptoms, and really they just want attention from us, this opportunity, we don't want to miss that, if we can save one life from suicide.
If you could, I'm not sure if somebody's unmuted. Okay, there we go. Dr. Moondyke. Do you have any other advice or comments for our audience?
I think, doing this for, since the pandemic started and having some like experts to help me, it's very empowering. I don't feel as helpless helping these children. And you develop a very close relationship with this family that I thought I would not have done before. So again, thank you for CPAN. You're always there. It's so quick to even call you. Wiley knows me already. And they're very good resources. So I think you ought to try it.
Well, thank you so much for taking your time today. We really appreciate having your perspective as a pediatrician. And so I'm gonna hand it over to Wiley, who's gonna share with us a story of his experiences.
Thank you, Dr. Munda. We really appreciate you, and thanks for the Q&A. That was awesome. I appreciate it. So I'm gonna make this pretty brief, so we can really open up to questions you guys may have. It may be more relative or helpful rather to you guys to ask some questions. So I wanted to share just some practical experience I had with two young men, teenagers that committed suicide while I was seeing them for counseling. So as I was preparing for the presentation today, I was kind of looking back over some of the things I've done. I've had between 300 and 400 crisis screenings over the last 20 plus years. I've seen between 100 to 120 patients for counseling. So I've had a lot of experience, but that has not made me immune, obviously has not made me immune to completed suicide. So the story I have is, again, I was working in a counseling center here in East Texas, seeing two teenage young men. Actually, there were just two of many on my caseload, not related. They came into the clinic for different reasons. The completed suicides happened 3 months apart. So the first suicide occurred, and then 3 months later, the second suicide occurred, again, for unrelated issues and problems. So I want to talk a little bit about the impact on me specifically. My first worry was for the family and their grieving, but I also wanted to kind of reiterate what's been mentioned already, is that I felt really selfish because I thought about their anger, potentially their anger towards me as a counselor, my liability also, and working with them and providing counseling. So we're all in a helping field. We're supposed to help people, and then something like this tragically happens. And so there's a lot of self-doubt and a lot of questions that come up along with completed suicide. So another bit that really affected me was there wasn't a lot of places to go. As a counselor, you would think I would have just tons of resources, tons of people around me to talk to. There wasn't. So counselors in the office that I worked in, great people, but they were not really prepared to help me. And so they did not really come to me and talk to me about specifically about the suicide. So outside of work, one of the young men I worked with worked at the local grocery store. And so I'd pretty much compartmentalized it and put it aside as I thought I did. And so one day, me and my wife were driving, and she asked me to just pull in the grocery store and go inside and get something for her, something real simple. And I started breaking down crying. So it was just right there on the surface of things I thought I dealt with and put aside. But that's where he had worked, and we had actually talked before. He had engaged me in conversation in the grocery store before. So it obviously has an impact. We're in a caring field. We're here to help, like Dr. Munda said, that we're here to help people. So other things that did not help in the process of going through those two completed suicides was, one, I headed up the team that was staffing the review for the suicides, and that should never happen. There needs to be somebody really taking a lead on that and doing that besides the person that was directly involved in the treatment. Time off could have helped, and then at the same time, the two suicides really contributed to really burnout and compassion fatigue and just really being numb as a counselor. So those things that were really unhelpful, and I mentioned those things because Some things you really want to think about as a clinician, as in your clinic or private practice, individual practice that you have, as you look forward and hopefully are planning to have something in place in your own practice to address these situations as they come up. The numbers that Dr. Curran mentioned earlier, they're great statistics, but there's also a human being behind every single one of those individuals. So something really important to remember. There's someone's daughter, someone's son. Things that worked for me and things that went right is that I stopped seeing teenage boys and young men for a while. There's something in counseling called transference. So I stopped seeing them because for a while, and I started again, but I was going to be overly and hyper vigilant towards anybody I saw moving forward. I was going to be extremely nervous, on edge, and I wouldn't think that would be totally dissimilar to what a physician may feel also if they've had that personal experience. The other thing that went right is there was a medical director that reviewed the patient's death. So that was a really good thing where I was kind of detached from that review. And then the other thing that was really good, the agency I worked for had a clear plan of accessibility for crisis services. So 24 hours a day, 7 days a week, every day of the year. The patients had access to crisis services if they needed it. And then also on initial paperwork with the individuals, it was clearly outlined. Here's what to do in a crisis. If you feel like you're suicidal, here's what to do. You can walk in. So it was in writing and accessible to them. So the doors were open to them to get help if they needed it or they wanted it. So again, it took me 15 or so years to get to the point where this happened to me. But like I mentioned earlier, I wasn't immune to this. And so I really want to encourage you as providers is that just because you don't want to or don't, maybe not see people for mental health, it doesn't make you immune either to your patients committing suicide. So with that being said, I would really, again, encourage you to have a plan in place, to be proactive. Certainly what's mentioned already is true. CPAN can really help out with suggestions or some outlines for some safety planning ideas. And I think on the upcoming presentation on the 15th, we're really going to cover that a little bit more, but we really want to be a support to you over the past 20 plus years. Professionally had an investment really to help and support children. And it's even more personal now since we have a 2-year-old son. So it's really important for me to have him to have access if needed to not just pediatricians, which are amazing here in East Texas, but also physicians and pediatricians that are really equipped if he happens to have a mental health need or emergency. So I just wanted to kind of end and then open it up for questions by saying that you definitely cannot do this alone. One thing I have with patients is no one's ever changed their own diaper. All of us on this call has needed help at some time, and that does not change once you're an adult. So we really want to support you. If you need some outlines, some guidelines, some suggestions on safety planning, and be proactive before this happens, before patients come and see you for your clinic or individual practice, let us know. So I really appreciate everything you guys do. So I'm going to turn it back over, back to the panel, and then just kind of open it for questions. Anybody may have.
Thank you. This was amazing information, you all. And so I'm going to start with sharing some of the questions that have been asked. I encourage those who are in attendance to provide some questions. I do have some that I have here already. So for Mr. Barnowski, you mentioned reporting when a child has suicidal ideation. Can you expand on that, please? Oh, you're on mute, Doctor. You're on mute, Carl.
Thank you. I probably sound more intelligent when I am on mute. But anyway, the Texas Family Code sets up a reporting obligation on the part of everyone to report child abuse. And these reports can be made through the internet or through telephone hotline. They can be made directly to law enforcement. But they do extend to a definition of child abuse that includes a suicidal child. They don't define that in the law, but if you see a child who is suicidal, we are all under obligation to report that. A professional is under a particular obligation to report that within 48 hours, as they would with any other form of child abuse under the statute. So that's, and that also establishes a standard of care for a professional, reporting or not reporting when they were otherwise deemed to have been obligated to do so. So it's straight from the code. So hope that helps.
So, Carl, I wanted to clarify on that. So when you say reporting, do you mean any patient that we see that endorses suicidal ideation, we should be reporting to CPS, or if we have concern that the parents are not addressing the concerns appropriately?
Yeah, the way the statute's been interpreted, suicidal child means more than ideation. Otherwise, there would be a substantial portion of teenagers and everybody that would be reported. It means probably someone who shows up who's had a recent attempt, just some additional indicator that someone was suicidal. But the definition, the difficulty is the definition's not there in the statute. And that makes it difficult. Makes it difficult for a professional. So, but definitely more than ideation. It'd have to be someone that has had attempts, that is, expressing a desire to do so, like in the immediate future. All of the clinical indications that someone is on the far edge of the curve there. So.
And then the reporting would be going then to the state, either through the electronic means, through their website, or a call to their number.
Yes.
Is that correct?
Yes. The internet's not supposed to be used for anything urgent. So given that suicidal is filtered to be urgent, probably best to do it via the hotline or to law enforcement. If somebody is like out and about looking for a way to kill themselves, then you might report that to law enforcement. So again, it's a broad range of judgment is applied here.
All right, thank you very much. I appreciate that clarification. So we have another question. How do you handle a child in crisis needing immediate attention or admission? So, CPAN is not a crisis line, but I'm going to put this to either to Dr. Kerr and then to Wiley, because we have had calls like this. Dr. Kerr, first, how do you recommend handling that? If you were as a pediatrician yourself, how would you handle that in a clinic setting?
Well, so I think this is where Wiley touched on. It's really important to have kind of a clinic policy or protocol about what you do. Kind of just like basic considerations that if I have a patient that I feel like, as Dr. Munda mentioned, you kind of stratify risk first. So I'm first going to try and get at the risk. Are we at an acute risk? And it sounds like that's what you're asking about, Dr. McGay. I'm going to say your name wrong. I'm sorry. McGay. And so if I'm really thinking this is one of the immediate risks, I am going to kind of, you want to establish, like, do I feel like family is reliable to take them to the hospital? That is a risk. The other option is an ambulance transport to the emergency room. But if I don't know if Carl has a thought on if that's inappropriate, if I feel like the family's reliable, and maybe just calling and checking to make sure that they did get to the hospital. But sometimes I like to avoid, if it's not a kid I'm worried that's going to jump out of the car, I like to avoid that ambulance bill, I guess, for the family, if I feel like I can trust them and verify that they got to the hospital. But I would recommend, if it's an immediate risk, probably emergency room evaluation or, admission, like going to an inpatient setting, because you just can't, unfortunately right now, I can't get kids in like for a child psych appointment. I don't have currently an acute kind of process to get, so waiting for an outpatient referral is not a good option in those situations.
There's some options with law enforcement and emergency detention warrants, but those have their own difficulties. And also, a lot of the case law supports for a variety of medical malpractice that a follow-up call can be part of the standard of care. Again, depending on the situation. Did the child actually, were they presented, where you recommended strongly that they be presented, and or was it an appointment made? That's a little not quite as often required, but there was a referral, a follow-up call to the parents that did you actually make an appointment? It's not your obligation to make sure that they have the appointment, but a check can, it doesn't hurt, and it could be part of the standard of care determination.
Thank you. Wiley, will you jump in here, please? Because it's when a call comes in, you or Elizabeth are the two that will answer this call.
Sure. So I would say ditto to everything Dr. Kerr said for sure, as far as the facilitation of getting kids some help. Obviously, the exception is if they're in your office and you're in your clinic and they're actively doing something to harm themselves, or they're running out of your office into traffic, call 911, of course. But if the child, like I said, Dr. Kerr said, if the child and parent are agreeing to, yes, I need help, I'm willing to go, then we can help out with verifying if hospitals have beds available. And now those come and go really, really quick. With a matter of minutes, those can change. So, but you don't want to necessarily, put someone in a car to a hospital and they get, 70, 80 miles away and there's no bed available. The other option is the local mental health authorities. I can tell you from my experience working in that field is that the state hospitals, which that's the only place they have an option to send a child, is there consistently a wait list. So that would not be the best option, but it is an option. So if the kid has private insurance or Medicaid, then seeking private hospitalization is the best option.
All right. And Wiley, I heard something mentioned about clinics having a safety plan. Can you share a little bit about how we may be able to assist clinics? All clinics should have a safety plan or a crisis plan in place for children where there is a crisis such as this. Can you share how we can assist with that, please?
Sure. If you give us a call and you let us know that's something you're interested in developing for your clinic, so we want to help you with a solid outline and specifics. Who's really the point person for if a crisis arises? Who's going to be giving us a call, or who's call 911? Who's going to be have an outreach to the local psychiatric hospital? If those plans are not in place, then you have a lot of scrambling going on, a lot of confusion. You have people stepping up that don't necessarily need to be making phone calls, or you may have front desk staff fielding a crisis at the front desk because someone's told them that they're suicidal. And so having something in place ensures across the board communication with everybody in the clinic about what to do, and having that posted in the clinic or having like annual or semi-annual trainings could be really helpful. And I think it makes the staff feel confident and comfortable and something they can refer to. So we don't want to dictate exactly what your clinic does. That is something within your clinic that we want you to do. You have complete control over that and who's designated. But we can help out, give you a really strong outline of what we would suggest and something in writing that you can even change or edit as needed. But we'll give you some suggestions on how to address those as they come up.
Great, thanks, Wiley. We don't have any other questions at this time, but I suspect there may be questions that attendees have. When you complete your evaluation today, if you would add those questions into that evaluation tool, we'd appreciate it. If you have additional opportunities for us for CMEs, we'd appreciate that information as well. I'm going to share 2 more pieces of information and work really hard to get you out of here by 1 o'clock, as I know many of you have patients that'll be in there at 1 o'clock. So one moment, please. Let me go ahead and share my screen. And I am not doing this very well. 1 second. So just to give you a bit of information for those of you who are not familiar with the Child Psychiatry Access Network, we are in the state of Texas, across the state. We sit in 12 different regions, all sitting in academic health-related institutions. Think of us as sitting in medical schools. And the services we provide are child and adolescent psychiatry consultation. That is a real-time consultation. You can give us a call and speak with one of our psychiatrists, such as Dr. Kerr. I'll show you the rest of the team here in a moment. Our basic turnaround time from the time you call to the time we call you back is about 5 minutes. That was our metric last month. Now, I can't say it's going to be like that a year from now, but we do have to hit a 30-minute response time. You can also call and schedule a time for us to call you back that may be more convenient. We can provide medication management, case consultation, dual diagnosis discussion, and just an array of conversations to support you in working with children with mental health needs. We can also provide some support with non-pharmacological intervention, such as evidence-based alternatives to medication. You may have families that don't want to do medication, but maybe the child does need that. So let's take a look at some options that are non-medication related. We have a number of screening tools that we will provide you that can help you with your assessments, and then safety planning and crisis planning, which Wiley just mentioned. The last piece is for the main portion is care coordination. We will identify resources and referrals for you that you can then share with your families. We never are patient facing. It's your patient. You have that relationship with them. But if you call and you need a psychiatrist, we can certainly help you with that. It may not be that you can have a psychiatrist visit for that child for 3 or 4 or 5 months based on backup time, but we're here to work as a bridge with you until that child can get into that child psychiatrist. Also can assist with identifying therapies, for example, ABA therapy for autism, and also counseling and such. And the last piece is the education for PCPs. All of these things are paid fully by the state of Texas. Our services are at no cost. Sounds too good to be true. It's really not. We're here Monday through Friday, 8 to 5. With the exception of institutional holidays. You're going to get Elizabeth or Wiley when you call. If they're away or on calls, you'll get the B team, which is me. So we'll make sure that we are taken care of and work around your schedule as best we can. There is never a limit on the number of calls that you can make in total or on one patient. So this is our team. We are excited to serve you as we possibly can here in the future. If you want more information, please contact us. You have information about our CPAN program through emails you've received from me. You can also get that through the consortium website. Lastly, here, let me go ahead and give you a view on the code you need to do your evaluation. So let me try this one more time. All righty, here's your code. And it is also in your chat. And then Wiley has added the phone number to give us a call if you have any questions. I'm going to open it up. Any other questions while we're on here?
Say, Laura, this is Carl. I had one thing that I'd like to add. I do have a paper in 5 pages, big font, no Latin, that has some of the information that I had here. Happy to just send it to anybody who's interested. I also sent you a copy for distribution.
Great,
If you like.
thank you.
Sure.
So yes, if you'd like a copy of what Carl has provided for us, just let us know in your evaluation or send us an email at cpaninfo@uthct.edu. That is cpaninfo@uthct.edu. As I mentioned earlier, my goal is to get this recording posted on our website by the end of the business day. Please feel free to encourage your colleagues to take a look at that as they have time, and to also reach out, and we would love to share more about CPAN. Thank you much, and you all have a wonderful day. We hope you join us on the 15th of September for the second half of our panel, which will be have 2 of our psychologists and 1 of our therapists on that panel for you. Thanks, and have a great day.